the following findings should we expect? Do we expect them to be bradycardic? Do we expect them to have diaphoresis? Do we expect them to have nocturia? Do we expect them to have bradypnea? So one by one, where's the heart rate going to go? If the patient has a kidney stone, it's going to go up because they have pain. So bradycardia is not going to be your answer. Do we expect them to be diaphoretic? Yes, we already talked about that. The patient with a kidney stone, we expect them to have diaphoresis. Do we expect them to get up during the night and pee? No, we didn't talk about that. Do we expect them to have bradypnea? What is that? That's low respiratory rate. No, we expect them to have high. And don't say, well, the patient got morphine, it's going to make them breathe faster. Nobody said that in the story. So don't read into the story. Just pick the one word that you expect you're going to see the patient and what expected symptom they're going to have. We already talked about what cystitis is. So again, it's an infection in the bladder itself. Those are signs and symptoms. Many of the signs and symptoms of a UTI, no matter where it's located, are pretty similar. Remember, if they have nephritis, that's where we know it's inside the kidneys, polynephritis, so that might be more flank pain. Cystitis, many times can be flank pain, but it might be in the bladder area itself. The patient has dysuria. They might have pain right above their pubic bone, right in the middle. That's where the bladder is located. They might have cloudy urine. They might have strong, foul-smelling urine. They feel tired. They feel weak. They might be running a fever. That's a cystitis. That means they have a bladder infection. What are we going to do? Well, we're going to get a urine sample. It might be a UA. The doctor might order a urine CNS. Now we're getting at the culture and sensitivity. But until we get that culture back, we're going to start them on antibiotics anyway, because we know they have signs and symptoms of this, and we don't want them to get any sicker. We're going to have them drink cranberry juice, helps maintain the pH of the urine, makes it a little more acidic and not alkalotic. Remember, we want to keep it within that range, but cranberry juice does help, so it's not an old wives' tale, it actually is true. Increasing fluid, like taking in more fluid, up to 3,000 ml or more a day. We might do a sitz bath just for comfort. We're not going to have them sit in a bathtub. We're going to have them shower. It's going to be some of the same interventions. Doesn't matter. It's a UTI. It's a form of a UTI. There's some meds that we might use, and these are antibiotic medications. Another med that we use for cystitis management is called pyridium. It helps with the urinary pain. Remember, if the story says the patient got pyridium, it's going to turn their urine orange while they're taking it. It'll get better. It doesn't say orange forever, but it's expected. So the patient doesn't have to call the doctor and report it. It's an expected thing if they started on this medication for UTI. Here's our same things that we talked about before. Wear cotton underwear, avoid baths or bubble baths. Cranberry juice daily. Okay, we already talked about polynephritis and what it is. If the infection has traveled from the bladder into the kidneys, now it's called polynephritis, or you might hear the term just nephritis. What is it? It's an infection that's in the kidney itself, and look at it, same thing. Majority of nephritis infections occur from E. coli, because it's normally found in our bowel, so it's easy for it to, if the patient doesn't wipe from front to back, if there's some kind of contamination, it's easy for E. coli to travel into the urinary system. Again, there's some other causes that can create nephritis, but I just need you to understand what cystitis is. What nephritis is basically just means that there's an infection that now has traveled into the kidney itself. Specific type of urinary infection that generally begins in the urethra, but now has traveled up into the kidneys. And again, could be a medical problem. A kidney infection can permanently damage the kidneys and spread to the bloodstream, and that would be called urosepsis, and that's what we're trying to avoid. They have pain. They usually run a temperature that's called hyperthermia. The neutrophil count goes up. The white blood cell count goes up. It's not any different. The last thing that's on here is just talking about glomerulonephritis and what is that, and then we'll be done. Basically, glomerulonephritis is an infection that now has actually damaged the glomeruli. Remember, that's the filtering unit of the nephron. That's the smallest portion of the nephron in our kidneys. What is important to know about glomerulonephritis? What happens, what's the biggest complication is the patient's blood pressure goes up. So again, what is it? It can be caused by different infections. One of the things that sometimes can trigger glomerulonephritis is infection somewhere else in the body, like strep throat that wasn't treated, and actually this bacteria has now traveled and lodged itself inside of the glomerulus, inside of the nephron within the kidney. So again, early diagnosis, prompt treatment. There is an acute form, there's a chronic form of this. Sometimes it's triggered by a urinary infection that wasn't treated. Sometimes it can be triggered by other infections in the body that weren't treated. So look how this usually happens in children. Prognosis is good if it's treated. It can follow a strep throat infection or a respiratory infection if it hasn't been treated. So again, you think strep throat, okay, well, it's not really a complication. Remember how before we talked about strep throat, and if you didn't treat it, it can affect heart valves and can create rheumatic heart disease and things like that. Same principles behind this here. Glomerulonephritis can also happen if a patient has strep throat and hasn't gotten it treated, or respiratory bacterial infection, not a viral infection, not a cold, but a bacterial infection. And many times when they do a culture of that kidney or do a biopsy or try to figure out what recently the patient had, they might have had a history 2 weeks ago of having strep throat. And I didn't finish my antibiotics, and now I've developed this severe kidney infection, and glomerulonephritis can happen because of that. So basically, it's an acute disease caused by infections such as strep throat or a UTI that wasn't treated. It can be caused by other illnesses. Things that happen, the important thing about glomerulonephritis, the patient's urine output goes down, their blood pressure goes up. So the biggest complication is severe hypertension from this. That's the bottom line. Again, there's some things that can trigger it. It follows other infections. But here's our signs and symptoms. Edema in the face. So you might see the face swelling, hypertension with a headache, increased BUN, that's a term called azotemia, where the BUN goes up, creatinine goes up, the patient has severe high blood pressure, they have swelling in their face, they have blood in their urine, they have pain, they become anemic. You can see the picture how sick this patient is because that inside nephron of the kidney has a bacteria has basically traveled there and affected the patient's functioning units in their kidneys. That's the nephron. That's the glomerulus. That's why I showed you that way back in the beginning. So here's your interventions. Because this patient has a severe kidney infection, it's not a kidney stone, we're going to maintain bed rest. We need to conserve energy for this patient. Because they have this, the nephron's not working, they have severe hypertension, they have swelling in their face, their blood pressure's up. This is not the person we're going to give fluids to. We're going to treat them with massive doses of IV antibiotics, get their weight, reduce their protein and sodium. One thing that's different about glomerulonephritis, that glomerulus is involved, the inside unit of the kidney, the nephron is infected. Because it's infected, there's so much inflammation happening, those units are no longer filtering and the patient is retaining fluid. So you're not going to give them more fluid. You're going to give them diuretics. You're going to give them antibiotics. It's a little bit different treatment than just a basic UTI. So I hope everybody's following that. Again, steroids might be used because it's inflammation that's happening. They might have to give them blood pressure medications. Again, this is inflammation of the glomerular capillaries, usually following some kind of strep infection. So it could be, we did a urine sample and we see beta strep, that's what the bacteria is called, in their culture, their urine semen. It might be that they have facing strep throat. Did you take antibiotics? And it did get better on its own, but now I feel worse 7 or 10 days later. It may be that the patient had a recent strep throat or respiratory infection, and I took the antibiotics for 2 days, but I thought I felt better, so I stopped taking them. So there's different stages of this. In a nutshell, this is usually a bacterial infection. It inflames the glomerular inside the nephron itself. The patient develops severe hypertension, so you're monitoring their blood pressure. You're giving them diuretics to help get their blood pressure down. You're not going to give them extra fluids. You're going to give them antibiotics and steroids and blood pressure medication and maintain bed rest and let that patient rest, especially in that acute phase. Because the more we get them up and walk around, what's going to happen with the blood pressure is going to go up even more. Again, doing lab tests will help us diagnose this. Sometimes they have to do a biopsy of the kidney. That's usually what's needed for us to really say this is exactly what's happening. But look what can happen if we don't get it treated. Extensive scarring of the kidney and damage to the kidney itself. So it's really important diagnosis that has to be evaluated and treated as soon as we can. And again, just read through this. Glomerulonephrosis is the third leading cause of kidney disease. So you can see how it can damage the kidneys themselves. It's again, depending on the prognosis and how early that we treat it. There's some risk factors. Primarily, it's an infection recently with beta strep. And strep is an infection that we said staph and strep are on our skin, but if we get a strep throat infection, it's not a minor thing, and we need to get it treated. That's the most common cause for glomerulonephritis. Other diseases cause high protein, high lean diet and create this significant damage. And again, this is what happens. High blood pressure, edema, especially in the face. They might get itching because uremia is building up in their system. And so they get itchy skin, nausea, vomiting, fatigue, difficulty breathing. Here, again, here's some possible causes. Can follow tonsillitis or pharyngitis. It's just an inflammation in the back of the throat. Might be a recent ear infection that wasn't treated. I mean, these are the things that you should be thinking in your mind could have potentially been the trigger for this glomerulonephritis. And again, it resolves if we can identify it and treat it and give them antibiotics. So look, about 10% of people who have this now develop chronic kidney disease. So that's important. That's 1 in 10 people who are then going to go on and their kidneys are going to shut down because of this. So it's a severe thing. Nephrosis and nephrotic syndrome we talked about here. Again, what is nephrosis? Happens when your kidneys start losing large amounts of protein in your urine. So look, there's in the med surg book, there are different chapters that talk about glomerulonephritis. I think it's only one chapter, one column. I would read through that. Things that are different about this versus just a basic UTI, that's where you have to start thinking, what is the patient going to look like if they have glomerulonephritis? What does it usually follow? Well, recent strep infection, how are we going to treat it? Steroids, antibiotics. Don't pick IV fluids. It would be monitored blood pressure or give blood pressure medications because you got to get your blood pressure down. That's what makes it different than just a basic UTI. Nephrosis is, we talked about, and there's a little column, I think, in the book about nephrosis and what it is. And again, what is nephrosis? The kidneys aren't working and protein is building up within inside the kidneys. And so you're going to see proteinuria, protein in the urine. And this patient, again, if they have nephrosis or nephrotic syndrome in your story, bed rest, low sodium, low potassium diet, intake and output, you're going to be giving them diuretics to try to flush out their kidneys. You're going to be giving them steroids to decrease the inflammation inside their kidneys. So this is just a chart that kind of compares glomerulonephritis, what you're going to see, who usually has it, what signs and symptoms they might have. And look how you see hypertension is really important for this person with this glomerulonephritis. What usually causes this? Recent streptococcal infection, recent strep infection somewhere. What are signs and symptoms? Well, edema. The urine is dark and murky and tea colored and lethargic. What kind of meds are you going to take? Antihypertensive and diuretics. This is glomerulonephritis. And this is a column just comparing what nephrotic syndrome is. Too much protein building up. The kidneys aren't filtering anymore. So I'm going to see an increased protein in their urine. They're not going to have a lot of volume. Who's at risk? Small children, age 2 to 7. What happens? The membrane within inside the kidney is no longer working properly, and protein builds up within inside the kidney itself. What are some of the signs and symptoms? The patient gains weight, they have edema. So you just kind of have to compare these two things, and if your story talks about glomerulonephritis, pick something that you recognize that had a recent strep infection. You're going to give antibiotics. You're going to monitor their blood pressure. Something that you recognize what the cause probably is. Look how this person has a headache. They have an increased blood pressure. They have periorbital edema, that means around their eyes. They might have a low-grade fever. They have protein in their urine. What are we going to do to treat them, get their blood pressure down, give them diuretics, give them antibiotics? This person with nephrotic syndrome, allowing protein to build up with inside their kidneys aren't working, the nephrons aren't working right. How are we going to treat that? That patient is going to get steroids. And this is just kind of a good chart to help us compare those two things. All we need to recognize from this PowerPoint that we're going over is these are different acute disorders that can happen to a patient in their urinary system. UTIs, cystitis, what is renal calculi, what is glomerulonephritis, what is polynephritis. You just need to be able to make yourself some notes and compare those different acute things that are happening to your patient. The most important thing about glomerulonephritis, keep this in the back of your head if this is in your NCLEX story, is blood pressure. Monitor their blood pressure. So again, it's different than just regular UTI. The glomerular are inflamed and infected, and you don't want to keep giving them extra fluid. That person, you're going to monitor the blood pressure and give them blood pressure meds. So it might be pick a calcium channel blocker. It could be pick a beta blocker that's going to get their blood pressure down, right? That's what you're thinking. Blood pressure management, and go back to what we know about blood pressure meds. It could be diuretics for this patient, because diuretics will help bring their blood pressure down. You're going to limit the sodium in their diet because you don't want more fluid pouring into their kidneys. You're going to limit the protein in the diet. So remember, this is a little bit different. You're not going to give them extra fluid. You're not going to give them sodium. Okay. So that's our acute disorders. I know we kind of went a little fast at the end here. All I want you to recognize is list out for yourself some notes about these acute disorders. Go through your chapters in the book and compare the disorders and how the treatment differs. And then tomorrow, after we take the test, we'll start talking about acute kidney disease and chronic kidney disease. I don't know what chapter it is in the book, but that's what we'll go over tomorrow. I'm not gonna send you today any more renal questions. I'll send it to you tomorrow. If I was you guys, I would study GI stuff, practice some GI questions again, make yourself a dynamic GI quiz. You know, whatever it is that you think will help you study GI topics. Again, don't memorize everything. How do I apply this to the patient with these disorders, and you know, hepatitis and cirrhosis and diverticulosis, and what's the difference between that and diverticulitis? That's the stuff that's on the test tomorrow. Okay. Anybody have any questions about the exam tomorrow morning? Yes, no, anybody still on here?
I mean,
here.
if you want to tell us what's the matching, you know, I would not be upset.
You would not be upset? Well, let me give you a little hint. There's some things on matching where you're matching up diverticulitis, what that is, ulcerative colitis, what that is, Crohn's disease, what that is. There's some stuff on matching. Hold on, let me look at the test, and I'll kind of give you a few little hints here. Let me get out of this. I'm not going to pull up the test for you to see, so don't worry, you're not going to see that. Stop sharing this. So, there it is. So it's not public, so you can't see it yet, but there are some questions about cirrhosis. That's something like that. And symptoms of that, and how we tell the patient to manage that, and different things in their diet.